Denise Sakuze Skaze, Hadi Sootsen, Travis Holyk, B-Sky Sathni. Masai Cho Tilkazko. Before I get started, I want to acknowledge my directors who are here or should be coming up to the front, because if there's any questions, as a department, health has grown, and so I really rely on my team now that does a fantastic job in their areas of expertise. Just with that growth, they are now experts in their own departments under the health banner. So we have Rhoda Hallgren, who is our Director of Community Health. We have Rachel Wells, who is our Director of Quality and Innovation. We have Marilyn Jansen, who's our Director of Health and Wellness, so our mental health and wellness team. We have Amy Merritt, our newest director, which is, as you'll see through the discussion, our Director of Health Promotion and Physical Activity, which is something that came out of the health plan. Tracy Day was unavailable because it's her son's wedding in the middle of the week. I don't know, in Vancouver they have to have weddings in the middle of the week, but it is her son's wedding, so we'll forgive her for that. And she is our clinical director, so she's the medical side of focusing on our addictions. And then we have another fairly new director, but not new to CSFS, Randy Mondor, who has taken on a role within primary care just because of the growth that we have seen. So the first thing that I wanted to talk about is really how under health we are doing things now. Within health, really we follow our health services plan, and that health services plan is derived from a number of methods of collecting information from the community. So meetings with leadership, evaluations, a bunch of different ways that we collect information in order to decide on what our priorities will be. So from that health plan, we've developed kind of 4 main pillars of services that we're providing. And so one of the biggest things that we have been doing is ensuring partnerships in healthcare. That's one of the things that we've heard, and even in the meeting today, everyone's talking about that we work for the community. So it's partnerships with the community to make sure that the communities are the ones driving everything that we do, and that's why the health plan is derived from the communities. And so the things that we're touching on there is with that, they need access to timely information, and we need to know through better communication what is happening with the communities. So as I mentioned, that communication includes quarterly chiefs meetings. Warner also touched on that. That's where we hear a lot from the leadership. We also have quarterly community health director meetings. And so those meetings as well is where our health directors say these are some of the challenges that we're facing. My whole team is at those meetings as well to provide updates on what's happening and get feedback from the communities. We have other leadership meetings that we also do in terms of the evaluation. We have community health lead meetings before the caucus, so that again we're united when we do go to either sub-caucus or caucus, and so Rhoda organizes those meetings to make sure that we come together, and any of the challenges that we're facing, we come up with a plan to bring forward to FNHA. We do community surveys, we do community and staff interviews, so particularly with the health evaluation, and part of what we also do in getting feedback, particularly I know there's always challenges with patient travel. We do, as well as Jordan's principle, we do have our health and social service advocates. So that's Pauline, who, when there are challenges, she advocates on behalf of clients. And she keeps records on what kind of concerns or complaints that are coming in. The last one was the evaluations, and that's Rachel's team leading a lot of mechanisms to hear back from communities about what they need. Mary also talked about the fact that nothing that we're doing is kind of done by accident. We're very strategic in what we do. So a lot of the programs that we have, whether it's even the jurisdiction, but also family justice, our primary care, all started as research. The primary care in particular, that is one of our kind of flagship programs now. started looking at kind of the mistrust of physicians and others within the healthcare system that kind of led to the push to have our own doctors, that Warner and Mabel negotiated that first contract. So we also, in order to ensure that our services are of a significant quality, we have CARF, which our survey is coming up in November. As part of that process, where evaluators come in and assess the work that we're doing, meet with different community members, meet with our partners, do evaluations looking at our files and everything else to make sure that the work that we're doing is of the highest quality. So how do we know we're improving the quality of care? We do that from a number of different ways, including reporting and tracking. So MOIS, you saw even the data that Matthew was showing, and I'll show some more data that we do have. We track kind of our outcomes with patients through our MOIS data. We do a lot of research so that we know exactly what the community needs are. And we do regular audits, as I mentioned, through CARF. So this data as well, in terms of our other goal, in terms of being kind of in step with the community, we want to make sure that our communities have access to timely information. And so we do that through quarterly reports that we share with the communities. And this is just some of the examples of the information that we do share with communities. So we know about the number of health visits. We know kind of how many times our practitioners are in community. We also know how many visits are done virtually versus in person, so that we kind of know how best to serve our communities and what services they like. I know with Marilyn, with her team, with youth, sometimes we don't necessarily have all the practitioners we need, but we do see that they are accessing virtual services on a more regular basis, and so we do know, oh, okay, like we are reaching youth. We also look at some other things like chronic diseases, and that helps us plan services. So with cardiovascular diseases being at like a higher level, I know that Randy has organized ECG machines to be in each community with our physicians, and those then can be analyzed by one of the specialists that we do have, Dr. Daisy DeLay, who is a cardiologist. She reads those reports and then sends them back to our physicians so that we can follow up appropriately. And so we're tracking those chronic diseases. We also track our prescription medications. So what medications are people on? And you can see like a lot of the work that we're doing when we talk about addictions, we have the opioid agonist therapy as one of kind of the things that we're seeing as a main prescription. You can also see from that cardiac meds, again, kind of our strategy around having a specialist in cardiology is based on some of this data that you're seeing here. This is also an example of a report, kind of the synthesized information that we do send. So this is specific to TACLA, but we do send this report to every one of our member nations, specific to their nation, so they know exactly kind of what's going on with the healthcare that we are providing. Our next pillar is equitable access to care. So the first pillar or kind of bullet of what we're trying to do is increasing infrastructure required to provide quality health services, improving recruitment and retention. We've done a lot of work with our HR team. So Brad Evans, when he was here, as well as now Kayla, has done a fantastic job. And you'll see that throughout the presentation as well. The good work we've done around strategizing on how we've talked about nurses, how we make sure that we have quality people. Increase mental health, primary care, diet and exercise, and allied health services. So in the community health evaluation, diet and exercise were two of the main ones that actually came up as challenges that people talked about. Another thing that particularly at the board level people want to see is developing an oral health strategy. So we have been working with Northern Health, but it's been kind of sledding uphill. It's been a real challenge. So I know communities like Notley, there has been a focus where they are inviting dentists to the community, and so we're looking at models like that. We've also looked at like the payment model of dentists is very different, so that becomes a challenge as well. So in terms of that equitable access to care, we will have a foundry now in Burns Lake and in Vanderhoof. Just across the street here, you'll see that capital project coming together. So the foundation is in, the wood framing will be up this month, and the roof is scheduled to be on in November with a scheduled opening date of around kind of, we'll say spring, summer, just to be conservative. I never knew that much about change orders until we started with the Healing Center, as Warner can attest as well. And so with Foundry, that's specific to youth, but it focuses on, so 12 to 24, but it focuses on core areas when we talk about holistic approaches to health. The Foundry model reflects that as well by focusing on primary care, mental health, peer support, social supports. So they're 5 pillars. Also with that, thank you to Silcasco, which the McPhail Road, I know, is an area that they had a specific claim for, and so we're really thankful that we will be able to turn this into an area that will really benefit youth in the community. We've done a lot of work with all of the nations and actually everyone in Burns Lake, because it will be, the services will be for the entire community, both Indigenous and non-Indigenous. And I think that now there may be more, but at the time, there was only 2 Indigenous-led foundries in the province. And so we're really thankful that we can be the one to bring these services to the community and make sure that it has that Indigenous approach, but also that like it is like a recognition of the strength of Carriacou County Family Services and the services that we can provide to the community. The other piece with the Vanderhoof Foundry is that when we wrote that proposal, we want it to be a network. So obviously there's a lot of challenges in Vanderhoof with the youth there, and so absolutely needed, but also in Fraser Lake with some of the things going on, we want to develop a corridor where we will also be supporting the communities in Fraser Lake with the foundries that we do provide. In terms of the build, I just put this picture in here, and Tracy's up next or soon, and she'll speak to the construction. I'll speak a little bit more about the operations side of it, but I just wanted to make note that this is another one of our big capital projects when we talk about increasing the infrastructure. Also in that kind of areas for us to focus on, you could see that mental health was one of our biggest concerns that people are needing, both through the data, but also kind of the feedback that Marilyn's team receives. And so some of the things that we have done in child and youth mental health is add virtual services. We've added a psychologist to the team part-time, and we've also focused on revamping art and play therapy spaces for in-person sessions. In community mental health, we focused on grief and loss in the past year. The community mental health has completed Strength in Solidarity men's events, and we've added new positions to help with the administration of the program. So we're really thankful to have Fiona Demers as the new manager. So Fiona was part of our very successful intensive family therapeutic services, and that program in itself, like in terms of charting and everything else, is one of kind of our exemplars of how charting is done. And so we're thankful that she's kind of leading that team now to make sure that services are coordinated to the best of their ability, which also then helps with recruitment and retention when you have a strong leadership core. Another thing that we have done is recognizing that not always do people need a specific clinician, they also need those mental health support services. So we've added to that team, adding a mental health support services manager. We continue to provide outreach in all of our programs. Oh, I should mention in mental health, and that's Janet Newski, perfect, yeah, absolutely, yeah. I've been mentioning a lot of names, and if I don't say someone's name, it's not out of disrespect, and like I am thankful to our entire team. And so the other thing that Marilyn did work on that will now be transferred to our legal services is the work around those who are left out of the residential school, day school settlement. And so she collected data and just to determine kind of experiences of people with Rachel's team too. So that's also part of the partnership of everything that we do, is the integration of our various teams. In primary care, we've seen some growth there. So the director of primary care, Randy Mondor, Katie Cornish, who will also be leading our Foundry Vanderhoof, but has really excelled in fundraising as well. So the Foundry in Burns Lake, when we first kind of did our assessment of what it would cost, it was looking at between 3 and 4 million. It actually is closer to 12 million. And Foundry, although it's a provincial network, the funding that comes from Foundry is actually less than $2 million. So Katie had to raise another $12-ish million for us to get that project off the ground in the way that it needs to be done. So kudos to Katie in that area. We've added to our nurse practitioner team. So this was another FTE, so full-time equivalent, a full-time position of nurse practitioner services, and that's Sienna Pollock. And we've added a medical office assistant. So again, you always need that infrastructure to support our teams. What this all translates to is over 10,000 in-person appointments with our medical providers and 4,000 plus virtual appointments. And that includes close to 2,300 different patients within the CSFS Health Network. And also with that, we talk about the integrated care. We hosted over 80 integrated care team meetings. So what that actually means is that any of our providers, if they're having challenges with a particular area, they can bring one of those patients to a integrated care team meeting and say, I need assistance, or this person needs additional services, and they come together as a team to determine what the plan will be. That plan is then documented in MOIS, and people check off the services that they will provide and when things are completed. Last bullet on there is, again, our Indigenous patient liaison, who was Taylor, who has now accepted a new role, but she saw over 1,800 patients and families at UHMBC. The hospital in Prince George has added additional patient liaisons, and so one of the things that we will be working on is our push will be that since they've added additional patient liaisons, that when we rehire, we want our patient liaison to focus on carrier and Sakani patients. One of the challenges that we do here is about discharge planning and not necessarily knowing when somebody comes back to community, the services that they have been provided. And so we're going to meet with Northern Health and address that issue by saying we want our patient liaison to focus specifically on our clients. I've touched on this one as well. So again, in terms of increased access, we continue to increase the number of specialists that we do see. So we do have a psychiatrist on our team, and she's actually doing work around, it's called C2C, clinician to clinician, where it's kind of unheard of in the province, but rather than going to see a specialist and then the specialist, well, the doctor writes a referral, our patients go to see the specialist then writes a referral back. We actually are virtually having a meeting with the specialist and the our physician, so in the same room at the same time, real time, around developing plans for our patients. So we're miles ahead of what anyone kind of in the province receives in terms of the care that they receive. Again, I mentioned the ECG machines. Another of our focuses, just based on some of the information that we are seeing, is around sexually transmitted infection screening. And then we also have been offering weekly opioid agonist therapy at the clinic. We used to do it kind of throughout the week, and one of the things that we are seeing at UBA is we now have a number of families and children that are also accessing services. So we didn't necessarily want to be having patients that may put others at risk, or potentially like moms in waiting rooms with babies that didn't feel comfortable. We want everyone to feel comfortable. So we've now added that as a specific day where we're doing a lot of our opioid agonist therapy. The health promotion and physical activity team is really a cool program, and I think Amy probably has the best job in all of CSFS, because she actually gets to do all the sporty things that I would love to do. So it's really about supporting healthy lifestyles through recreation and sport. It's services for all ages, and Amy also wanted me to plug a few of the events that are coming up. So one of the things that also was online, the questions was about supports for elders. And so some of the things that Amy will be doing, again, with this program, it is about keeping people active. And so she's got a program called, and you probably won't be able to see this, and I guess with that up there you won't either, but it's Don't Fall This Fall. So it'll be a program working with anyone, but primarily with our elders, focused on balance, strength, and mobility. And so that will be in the Burns Lake area, and it'll be Tuesdays every week at 11:30. Correct? All good, Amy? Yes, there you go on that one. Another thing, when we talked about, there was a lot of challenges in that evaluation around musculoskeletal issues. And so one of the other partnerships that we do have that's coming up in Notley is an arthritis wellness program. And so that'll be starting in Notley. For youth, we also have a Pro D Day youth swim at the Houston Leisure facility. So lots of different cool things like that going on with the team. And again, this was all based on, so we had a partnership with UBC. They did research around kind of what activities people would like to see. So again, we started this with research to see what are some of the things that people would like to see. So from that, you can see swimming, walking, and that's some of the activities that we have been doing. We also looked at like, why are people unable to potentially participate in different activities, and so that becomes the core of how Amy is delivering programming. She's also working on ways to evaluate the effectiveness of the services that we're doing, and Mac is kicking around as well. He's the physiotherapist on Amy's team, so he works in coordination, so helping with people to be active, and we've looked at how we're evaluating the success of that program. Examples of some of the programming that we did in 2024 include Try It Sports Days. So again, that was every Tuesday, was it not? Where they were in community and just had a different sport for youth to try. All the equipment was provided and transportation. We had a hockey camp, which the pictures that are cycling over lunch and at different periods, you'll see a lot of those activities. We had a Learn to Skate, which we will be doing again. People have asked about the hockey tournament that we've done in the past. The goal is that hockey tournament will happen again this year. We've done elders tees, Learn to Lift, hiking groups, all those things that people needed to see to keep active. Other things that we do is work with the healthcare teams to ensure that holistic wraparound service. So one of the things that we'd like to see from our docs is maybe even prescriptions for physical activity. And I know right now that Amy does work with MAC, with our docs, with the care aides, so like chair yoga and other things, co-developing programming to support the programming that they do. Just wanted to throw in these slides to recognize a few of the other things that we do. So Jordan's principal, I know, how long have I been talking, by the way? Or am I done? Am I good? All good? But, okay, so Jordan's principle. So again, strong advocates for our communities. Our coordinators, if you look at even the number of services that we provide, and I'll provide that on the next slide, the amount of people seen and supported through Jordan's principle outweighs. And Rhoda, what is the number of that they're expected to provide? 35. And how many generally do we provide? So they're expected to provide 25 cases, 35 cases, yeah, a year. And we're about 10 a week, just to give you an idea, per coordinator, yeah. So again, we're excelling beyond kind of expectations of what it is. And so with this, there is the criteria again, and that's with both this program and patient travel. I just also wanted to highlight that we do it because we want to advocate for our communities and we feel like we can do a better job, but we still are bound, in this case, by ISC policy, and when we get to patient travel, we are bound by the policies of FNHA. But we do it in order to support our communities, and we also, with both of those programs, really follow up with ISC when there is denials and push and advocate when there are denials. So by the numbers, we provided services to families from 55 different First Nations. We submitted applications for 254 children residing on reserve. ISC approved 57 of those applications. There were 509 applications submitted for children residing off reserve, and ISC approved 191 of those applications. So with First Nations health benefits, again, it is based on the FNHA Health Benefits Guide, which the policy determines when people will be accepted. So things like escorts and whether or not even people will receive money, or the amounts, which the amounts have gone up for patient travel, but that is all determined by FNHA. We continue to do this program, even though it's one of those ones that people get really unhappy with CSFS, because of the way that our finance department and others are structured, that we can provide payment in a timely manner. And so really it's about services, because what is the time frame? I think it's that they have to get it in 2 weeks in advance if it's going through FNHA, whereas we still will kind of exclude that. And it's often done on reimbursement as opposed to being done based on like having money for individuals beforehand. So that's really why we keep this program, even though we're the ones not necessarily who make the policy, but have to enforce it. And then, as I mentioned, Pauline is available when somebody is denied, or when we do a benefit exemption and it gets denied, to further advocate because we recognize the challenges that it has for the communities. Our next pillar is culture as our foundation. And so really what we want to see is that with healthcare, and I know people were talking about earlier, even traditional healers and their role in medicines. We do provide support through traditional healers, and we have a way to subsidize the work that those traditional healers do in the communities if people do need traditional medicines. And then other things that we are doing, so all of our staff are required to take the Nokana training, as well as all of our health and wellness team has now attended a trauma-informed training. And we do have that in our overall plan as well, that we want all of our service providers to be trauma-informed. Another really important program, and kudos to Marilyn, this is really her baby, is our ATSU program that continues to grow. So we're continuing to train ATSUs. So okay. Now my team's having a how we pronounce this debate. But really, it's about grandmothers and those who don't necessarily have a grandmother and need that support, that cultural support. And so it's really strengthening the traditional roles in the community. And so we provide training for those to support people in community. It also is that kind of idea that within even the mental health services that we do provide, sometimes people just need a grandma as well, someone to kind of have to support them. The next training is October 21st to 23rd at BLNDC. See Janice to register. Again, to ensure that we are being culturally appropriate, we do things like, I mentioned evaluations, and I just threw this in as an example of at the Addictions Recovery Program, we actually receive community feedback that we then kind of roll into programming. And I should say that as we roll into Tatchik Lake as well, Rachel's team has done a number of evaluations of our services, and we also have looked at various models, but we've also done evaluations of the Addictions Recovery Program as well as some of our other services to kind of say, okay, this is how we can improve the services. The final pillar, and Ernie, I'm getting close to being done. The final pillar that we have here is around healthy and resilient communities. So one of the major things, and it has been touched on here as well, is expanding our addictions recovery and healing supports and services. And so with that, again, we've partnered with the University of Toronto around looking at substance use and addictions, making sure that it both aligns with our community priorities and also where our communities are at on the spectrum of kind of prescribed safe supply to abstinence. So we need to make sure that it aligns with our communities, but we also need to make sure that our providers are comfortable with the way that we are providing those addiction supports. So we've done research around that to make sure that everything is aligned. And then with that, here you can see the growth in the amount of support that we are providing for individuals with addictions. So this shows our trends around the number of appointments that we are having around addictions. And you can also see from this, another thing that we do look at is individual patients and also the number of visits, because sometimes we have people that require a number of visits, and so it's not necessarily just patients, but also number of people and then the number of times that they're seen. Another application that we did and were successful, again, on that kind of compendium of services was the Sobering Center. And so that one is led by Sue. The Sobering Center, the best way to explain it is almost going to an auntie's when you've had too much to drink. So it's a safe place. It's non-medical, but it allows people to go in a safe place rather than being picked up by the RCMP or sitting in the emergency room or being unsafely unsupervised on the street. So it provides them a safe place to rest. So referrals can be made, people can just show up, but also like we've worked with the RCMP, Northern Health, and other community partners to make sure that if there is somebody, they're bringing them to the Sobering Center rather than bringing them to the ER, rather than putting them in the cells or rather than leaving them on the streets. We also see this as part of like our service provision plan, that we build relationships, and Sue's team does an excellent job at that, at building relationships. And I know Walter Ward and others have come down to the Sobering Center to see what we do there, and we're really impressed in the services that we do provide. And really, we try to do things in that trauma-informed, non-judgmental way where we build relationships so that then when we do have the healing center open, we can say, have you thought about like other alternatives to treatment that you may want to receive? And again, just some of the demographics that help us kind of understand our populations. the people are about average of 37 years of age. They stay at the healing center for 8.1 hours. We also track what they're coming in for, whether it's opiates or alcohol or marijuana or stimulants. We had some challenges with the building in terms of people with stimulants have higher heart rates, and the building was really hot this summer, and so we've been kind of working with BC Housing around addressing some of those challenges. You can see that the majority of people are self-referred, and one of the other things that we are seeing is that patients are typically Indigenous as well. So I believe that says, and I can't really see, my eyes are getting older, but I think it says 71% of clients are Indigenous. Does everyone agree? Excellent. With the Healing Center, a lot of work has gone into the planning. So we have various committees, including our HR committee. Kayla has been part of that committee, and we meet on a monthly basis to figure out there will be roughly 90 new employees for the Healing Center. And I know Warner says we're behind a bit on like the construction, but I don't think that's the worst thing because so much planning has gone into the model. There were questions online about the model as well. So it's Marilyn and Christina and Mary and others that have been working on the model, and it will be generally 50 days that someone will be. So I think it's about 7 days per module of services that we will be providing there. The detox will be a separate component, so we'll have 10 beds of detox or withdrawal management at the center as well, and 36 beds of healing. And so we've done a lot of work around developing that as well with the quality and innovation team. Another thing that we needed to do was ensure that we actually are compliant with all the rules for us to help me out, Rachel. What's the terminology with what we're applying for? Yeah, licensing. There you go. Our licensing requirements. I've been up here so long that even in my own head, I can't listen to myself. Some of the things that we have done is we've hired our art manager, Mary, and also our clinical director, so that's Tracy Day. So we're trying to hire positions that are key to when we get open, that are kind of the management crew, and that helps us in determining. So we've mapped out all of the different positions that we will need. We've also mapped it in the green, our existing positions, and then the other ones are positions that we will need to recruit for. So we've done all of that analysis. With that, we've done all of the budgets. There was a question online about how are you going to pay for the Healing Center. So with those budgets, I've had monthly meetings with Indigenous Services Canada, Northern Health, FNHA, Ministry of Mental Health and Addictions to figure out how exactly we're going to pay for it. And on the detox side, Northern Health and Ministry of Mental Health and Addictions has agreed that we're going to be one of 3 centers for the North. So we've done a lot of advocacy work to ensure that we actually have the funds in place to do it, as well as kind of mapping out all of these different, not that you need to see them all, but just gives you an idea of all of the work that we've done in terms of budgeting and also org charts to structure. And then finally with that, the other thing that we have done is this year at Ormond Lake, we actually did the medically supervised detox and withdrawal management for people. And our last group in September, 10 of the 14 individuals, or I think it ended up being 12, but 10 of the 12 individuals went through the withdrawal management. And so with that, all of our protocols for how we can do that safely have been developed, and we've had a lot of lessons learned. So Mary nodding over there, absolutely lessons learned about like our need for social workers or our need for primary care, where people have come off substances and then realized I have glass in my feet that hasn't been addressed for months upon months upon months, where then we have to get them into other medical services. So really planning for when we do have a full service center at Tatchik Lake that will be prepared for all of the service needs that they do have. And then I'll leave you with some of our work plan for the next year, which is to grow the ATSU program. Again, we're always working on improving communication. We will finish off some of those capital and infrastructure projects. So the Healing Center will be open next year, as well as the Foundry in Burns Lake. We're also looking at program sustainability, so continue to push FNHA on sustainable funding. We haven't had a contract in place with FNHA for 2 years, and so we meet with them on a regular basis, really based on the health plan that we did map out, again, all positions for that as well, around needs in the community. And we continue to do operational planning, so HR plans and implementation for our various projects and vacancies. We talked about nursing, but we have vacancies that we work to address. And with that, I will say Snachalia.
Thank you, Travis. That's a lot to absorb and even more to unpack. That being said, so any questions online? So we'll keep it to 4 questions or comments. Questions, I guess. So let's hear the first one online.
Okay, we've got questions from online. We also have questions that we solicited from community members over the past weeks and month. So I'll start with the online question. First one, is there a plan for primary care centers to be set up within the CSFS communities?
Good question. We already have our network of primary care, but the First Nations-led primary care initiatives, we actually pushed for additional CSFS primary care centers. We've been pushing for funding. Within the Ministry of Health and FNHA, their argument is those have to be new spaces with new attachment, and they have made the argument that because CSFS has its primary care program, that there isn't new attachment. And we have argued that we have a number of unattached patients, and so Warner in particular at every meeting says you can't build new primary care centers without adequately supporting our network of primary care. And so at this point, there's no plan for additional specific centers within Kearsley territory, but we continue to advocate for that, and in particular, advocate for additional funding. So for example, when we moved to our cloud-based electronic medical record, that now costs us over $100,000 a year, and that cost is covered under the First Nations-led primary care initiatives for centers that they do open, but we don't receive that funding, and so we're saying it needs to be equitable within the Kearsley network of services as well.
Thank you. Next question. Can there be services towards IRS survivors led by Kearsley personnel? And I see you have Marilyn coming up.
Hi, everybody. My name is Marilyn Jansen. I'm the Director of Health and Wellness at Kearsley. For our IRS program, it sounds really wonderful to say we have an IRS program. The reality is we have funding for one IRS worker. We do partner a lot with IRSSS, who is a fantastic organization, at a number of events that we provide cultural and emotional support to. Our IRS worker has a very large caseload, and she travels to all 10 of our communities. Not everybody knows the acronyms. Okay, Indian Residential School, and IRSSS is the Indian Residential School Survivors Society. And shout out to Mabel Louie, who's on the board for the North. She was the one who advocated really hard for Kearsley to get some funding before the development of the other organizations, and we've been able to maintain that small pot that we do our best with. Does that answer, Andrea?
Thank you, Ms. I.
Okay.
if I may, I know that there are people waiting, so I'll just get through a couple of questions that we received ahead of time from community members who couldn't be here today. You did answer a lot of the questions already about TACHIC. Just a couple operational ones here, and I'll ask them all at once. How many days is the program? Will it be similar to what's been happening in Ormond Lake? And is there any services for anyone interested in workshops for progressive health after 10 weeks of treatment that doesn't require transportation out of community?
For sure. So the withdrawal management side is depending on what people, obviously we tailor to their needs, but it's generally 5 to 7 days. And then on the healing side of things will be 50 days. With that as well, there will be, we're also working on second stage recovery. So we recognize that some people 50 days will not be enough. We also recognize that those supports needed to integrate people back into community are really important. And so there will be the second stage recovery as well. And then the last question on that was?
Regarding post-treatment support or workshops for ongoing health that does not require transportation.
Do you want to speak to that? I will say one thing about that as well is that, there was a question about will it follow the model of Ormond Lake? So yes, to an extent, different land-based activities, but that two-eyed seeing approach, absolutely, like that it will follow in that way. The other thing that we have been thinking about is with Ormond Lake, because it was seasonal, we did provide workshops in the community, and so that will change once all of our workers are at the TACHIC Lake Healing Center throughout each season. And so we recognize that some of those community-based workshops that are really important, that we probably will need to continue with those, but we will need to receive or obtain funding in order to continue with that work. And then I'll let you.
Yes. So we do want to have an outreach program that continues because we've had it with Ormond Lake for all of these years, but also in developing this, we've never done a continuous intake program before. Everybody comes on the same day and everybody leaves. Our community said that's not good enough. When somebody is ready for treatment, we need to be able to get them in right now. So that's why we're moving to a continuous intake model. And so after treatment, we went out to other treatment centers and we were learning from them. We were asking them as many questions as possible, and they answered all of our questions. And one of the things that we learned was about an alumni program, so that people can stay connected to peers through a program that we'll be able to offer after somebody leaves. And we want it to be virtual based simply because of transportation issues. Mabel, go line up. I'm just kidding.
So Mabel, nobody could hear you online or in the building, so you're gonna have to go back to the microphone and ask the question or make your comments. That being said, here it is.
Marilyn was talking about outreach, or a question about outreach. Marilyn, remember FNHA funded Williams Lake as the only treatment mobile when CSFS did the same thing. So couldn't they do that for your program now that treatment center is all year round?
Yeah, we have added the positions to the budget, but whether or not we get approval for them, but it is something we are actively advocating for.
So I see 3 folks at the back at least. Gonna take your questions, make sure they're laser focused questions, nice and tightly asked specifically, so that we could get the most out of this. I'm driving here for a break because it's been about an hour and a half since we started the session in the afternoon, so go with your question.
Travis, in the past, for our community, with Silcasco, we are a very small band, and I know funding works per capita. And I don't know how much people are aware, being a small band, it's very challenging for our community, especially when it comes to home support worker. And how is CSFS is going to, because even though we're a small band, we matter. We should matter, because it doesn't matter how much numbers we have, but I really need to, someone needs to consider about the policy needs to be changed. I don't know if it's with FNHA or whoever, but right now we can't even hire our own family members. It's not by choice, it's because our own family choose to want their own family to home support them, but it doesn't fall in the guidelines. And that's a gap and a barrier right there. And that's just one, so I don't know if someone can direct me or something, because that needs to be addressed within our small community. And another last question is, in 2012 or 2013, we talked about CSFS when I was part of this long time ago, about our own old folks home. Is that still in the plans in the future? Because we're all aging and we're all gonna need to be there one day. So we might as well get our own old folks home, because recently, one of our members is in the old folks home. He was diabetic, and they had to rush him to the hospital because he collapsed. Oh, there was no response. And so we all Zoom up there, and they said something happened. That's just one case. If you were going to research and do data collection on all the past, your numbers will be really high. But those are the only two things I really want to address, because that home support is our biggest challenge for a very small band. Like I said, we're small, but we matter, and we should be inclusive. Masaicho.
Absolutely. Thanks, Sherry. So two things, like I think there's two separate things. So we have home and community care that is CSFS, and one of the strengths of CSFS is that no matter the size of the nation, we make sure that we try to address the needs of the community, and I think that's the strength of an umbrella organization, that when we talk about some of the elders who designed Carrier County Family Services, that's what they had in mind, kind of supporting everyone. If you're referring to the homemaker, which actually comes through, I think it's Indigenous Services Canada, that's probably per capita and more of a challenge, but absolutely we can work with you to advocate to make sure that like small nations aren't forgotten on that one. In terms of the old folks home piece of it, oh, does Rhoda have something to add? Do you want to speak? Get up here.
Hari, Denise, Rhoda Holgren Zadni. So I think it was 2 years ago, we were contracted by Indigenous Services Canada to do the engagement for the old folks homes or the long-term care homes. And so we did that throughout the north. We went to Prince Rupert and everywhere to do that engagement piece with community members, specifically with those that work with elderly in the communities. And that was all wrapped up and sent back to ISK, and that's where it's sitting. So to answer that question.
We also did CSFS specific research back in the day as well, and that report we still have. So to further answer your question, we hear that, and even Warner says he's getting older and is gonna need a home, and so like definitely it is on our priority list.
Before we get to the next question, 50/50 tickets are on sale for $10. All proceeds go to the emergency fund, and it's clocked in at $520. So if you're into a chance at $520, it's your opportunity. Go see Benna. Alex.
Good afternoon, everybody here in this hall. My name's Alexandra Lugie. I'm a member of the Stellatan First Nation. I'm a recent graduate of, with a certificate with NVIT and First Nations Health Authority, they went into a partnership for the Indigenous Holistic Wellness Addiction Certification for addictions counseling. 11 of us out of the beginning of 26 have been successful. I want to ask the partnership, I had to go to another nation's health director to ask for support to attend this. I was the only one that wasn't attached to employment or something else. And by the grace of God, I had Nakasley's support because I live in Nakasley. I want to ask the leadership here, chiefs, health directors, to please support this program. We have 11 of us that are ready to go. It's sitting in FNHA's management right now for us to continue on in a diploma. My ultimate goal is to get a Bachelor of Social Work in Counseling, to be able to take one of the positions at Tachak. That's my goal. Hopefully it's on reserve so we get status income so we could get tax-free income. But I would just like to ask anybody that has a family member that's dealt with addictions, anybody that's lost a member that has dealt with addictions. I lost my brother to addictions on the downtown east side in 1998. And I think about him when I'm doing my coursework and working hard for our communities. Because mental health is definitely an issue, you've prioritized it. And I just want to ask all the chiefs, including my own, any health directors that are here, to please support the people that are working towards these. It's time away from our families, but it's in order to help our families flourish in our communities. So I just wanted to ask for that support. And hopefully that, it was great because Warner put a call out to our cohort to say, hey, don't ever give up on your dreams, and you may have an opportunity to be recruited by CSFS for Tachak. So I'm asking openly, my chief and other chiefs in the room, and anybody that can support the NVIT's Indigenous Holistic Wellness Addictions Diploma program to move forward to second year. It's important, and I can see the benefit to all of us. So thank you.
Thanks, Alex. I will mention one other plug is that one of the things that we do want to do at the Healing Center is become a center of excellence. So both within, like one of the things, like even Dr. Tracy Day, she had to go down south in order to get the training that she received. We want to ensure that we're actually training people in the north for our communities based on best practices that are CSFS led.
Just to note, most of us came from CSFF member nations as well as the north. We had students from the North Lake, Fort St. John, Fort Nelson. We also had from Prince Rupert, Fort St. James, Prince George, Southside too. So I just think something to think about to move forward, and especially for our retention and our recruitment. I'm hoping to either work with that to get the counseling side of it, or even as a primary care paramedic to see if I could slide into your guys' programming too, for a job long term, because I value our nations, and I think our people are our biggest resources, and the opiate crisis and the addiction crisis is so scary right now. So I really hope that we can have a vision for the future, which I see it here in this room, and I just want to ask for support for that programming. Thank you.
Thank you, Alex. So we'll give the last comment or question to Dave. So floor is yours, Dave.
Thank you, you guys. I've been going to quite a few meetings lately. Nothing going on back home anyways, and I'm always hearing pretty well the same stories. Come and have meeting, chow down, and at the end of the meeting, I'm kind of lost. It started out with Alkali Lake, but I think it's long overdue for a drug addict lake, and really get serious with making a real movie ourselves right here in the heart of BC. I mean, we have enough drug addicts here. I'm a living proof that you can quit drinking cold turkey, and you can quit drugs cold turkey. But I know a lot of people want to, but sometimes they get a shelter, but they're allowed to bring booze and drugs in there. I couldn't quite see the picture of that. But I mean, if we really seriously want to help some people, I think you gotta grind your axe a little sharper. Get some people that are really involved in trying to help these people out, because there's more drugs coming down the line that's 10 times worse than what we've seen already. But, I sure love what you guys are doing now. I mean, you get to hear people talk, you know, and when I first moved back here, I wanted the treatment right here in the heart of BC. Oh, that went to hell when right off the bat we started in third party. And there were a couple of somersaults, and then we got some chiefs in there, and we've been standing still since 1992. And it just pisses me off to see who's in them offices and what the Indian Affairs says. Spend the money where you want, but don't help the alcoholic or the drug addict or somebody that got a little bit of brains that might actually do something. If we can get some people that are really serious. I have a lot of people lined up already, ready to follow if I had some more people here that they got to pull where we can actually really start something here. Stop the bullshit and get down to, you know, let's do something. Let's change these meetings into, yeah, we want to help, here we are. Thank you, you guys, but we were kind of late on well, you're never late when it comes to the addict lake instead of alcohol lake. But, you know, it just really hurts to see them little kids never seen the world yet, never even seen the city of Vancouver yet. And, you know, some little things like that, it keeps me awake at night. But I thank all of you for being here tonight. I'm glad I came. I wasn't good. I'm not getting any older, not getting any younger. And so far I've done quite a bit, but the ideas went to the chief and counselors, and they used all my ideas up. I need somebody I can find that is willing to back me up, and just even to get it started for you. Because I know there's a lot of good people out there that really do want to try. And I'm one of them, and I'm proof that I can do it. And that's about all I got to say, and I wish you all a safe trip home. Thanks for being here, eh? Thank you. Adios.
Thanks, Dave, and definitely we hear that a lot of action is needed, and so hopefully Tachik will be a step in the right direction.
All right, we'll have one more comment or question, and we'll call it a break, okay?
Howdy, my name is Annette. I'm a Carrier-Sacani staff, but Rosie here, who is Dahkalan, Lake Babi Nation, has a question. She wants me to say it. So she's concerned about aftercare programs that people go away for treatment and then they come back and there's nothing for them to do, or, you know, they don't know how to get involved in different programs that they could access when they're home. But that's her question. It's about aftercare program.
No, go ahead.
Hi there. Thank you so much for your question. I was talking with one of the chiefs because they're trying to get through all of the questions quickly. But your question was about aftercare. For the new treatment center that we're building, this is one piece of a full continuum of care. I don't know if you saw the slide earlier, but the first part of that continuum of care was community, because we know that when they come to us, they're only with us for a short time. They may do 10 days in detox, add another 50 in treatment. Once we get second stage recovery, we're going to add more days, but they're going to go home, right? So we want to use this center, I think Travis mentioned it earlier, as a center of excellence where we're able to train people that are in community to be able to support them. Right now, there's not a whole lot of sober spaces for people that are trying to maintain a sober lifestyle. So how do we create those in community? And that is definitely lacking. And then when we look at our NADAP workers are working so hard. They're paid very, very minimal amounts of money. So trying to advocate so that we're able to increase wages so we can get people trained and working with a living income in our community. We know it's a gap, but it's about the treatment center, but it's also about the community and how is community and the treatment center supporting that work. Right now, we know we're not doing a good job, but we are trying, and we are trying to make it better. And we do have plans to make it better. Thank you.